All right, welcome everybody. We'll give us a few more minutes to get all the attendees in and get started in a minute or so. All right, so I wanted to be the first to welcome you all to the inaugural Virtual Pathology Grand Rounds, which is hosted officially by ASCP. As many of you know, you've probably participated in these events previously. VPGR was created as a way to maintain some continuity in pathology education via virtual platforms. And over the past year, we've seen its reach really grow, with participants joining from all over the US and abroad. So on behalf of the entire founding committee, which includes Raul Gonzalez, Sarah Jiang, Elham Kanafshar, Kamran Mirza, and myself, we're really delighted to present 1 year of COVID-19, the essential role of pathology and laboratory medicine in diagnosis, testing, and pathology. This event marks a year of navigating numerous clinical, educational, and personal challenges that we all shared from going through the experience of COVID-19. We hope that this kickoff event sets the stage for more opportunities for high quality, interactive virtual education for all lab professionals. And with that, I'll ask you as we go through these talks to please submit any questions you have for us via the Q&A feature. And we do have a slide showing our disclosures. And with that, I will turn it over to Dr. Kamran Mirza, who will introduce our first speaker.
Good morning, everyone. I echo Dr. Wapker's enthusiasm and welcome you all to this first ASCP Virtual Pathology Grand Rounds Kickoff Extravaganza. It is my honor and distinct pleasure to introduce our first speaker, Dr. Sanjay Mukhopadhyay. Dr. Mukhopadhyay is the Director of Pulmonary Pathology at the Cleveland Clinic and the Associate Editor for the Pulmonary section of AJCP. He attended medical school in India and completed residency at the very prestigious All India Institute of Medical Sciences, followed by a second pathology residency at SUNY Upstate Medical University in Syracuse, New York. After pulmonary pathology fellowship at the Mayo Clinic in Rochester, he was recruited back to Syracuse and stayed on as faculty for 6 years, rising to the rank of a tenured associate professor in 2011. In 2013, he joined the Department of Pathology at the Cleveland Clinic. His interests there include granulomatous lung diseases, including infections, interstitial lung disease, and lung cancer. The Pulmonary Pathology Service at Cleveland Clinic signs out 5,000 cases a year and supports a large group of interstitial lung disease pulmonologists and several thoracic surgeons. The lung transplant service there is one of the busiest in the world. Dr. Mukhopadhyay has authored more than 100 publications in indexed peer-reviewed journals and is the author of a lung pathology textbook published by Cambridge University Press. He is the recipient of numerous teaching awards, and for any of you on social media, you know exactly why. Since 2016, he has pioneered the use of online platforms for teaching lung pathology globally, for which the Pathologist magazine has named him to its power list for 3 consecutive years in a row. In 2018, Dr. Mukhopadhyay first authored a landmark study that led to FDA approval for whole slide imaging for primary diagnosis in surgical pathology in the United States. This was followed by 2 highly cited studies of the effects of vaping on the lung and autopsy findings in COVID-19 that have generated interest in national news media and online. In 2020, Dr. Mukhopadhyay was featured in a New York Times video on COVID-19 and ARDS that has been viewed more than 1.7 million times. And it is for that reason and many, many more that we're very pleased that he will be sharing his experience of COVID-19 in his practice today as our first speaker. Please welcome Dr. Mukhopadhyay.
Thank you, Kamran. That's such a generous, such a generous introduction. Thank you so much. I want to say before I start that I'm just in awe of the VPGR team, and just the continuous innovation that you guys do and bring ideas. It's just incredible. It is incredible to see not only that there is an idea, but then that the idea is actually translated into reality, and that it helps so many people it's already helped so many people around the world. And I think that everybody has seen the work that you and Sarah, Dr. Wapkar, the entire VPGR team have done. And that's why ASCP has really shown a lot of foresight in taking this over, just this wonderful series. So thank you for having me. I just want to ask somebody if you can just let me know if you can see my screen and if you can see my PowerPoint slide, and then I'll get started.
It looks good.
Okay, great. So thank you so much for having me. I'm going to talk briefly about our experience in lung pathology of COVID-19. As everybody knows, lung is really the target of this virus. So I'm going to talk to you about a little bit about the basics of pathology in COVID-19, a little bit of the basics of ARDS, and then I'm going to show you some very recent hot off the press literature that's come out from our institution where we have looked at late effects of COVID-19 now that we're almost a year out or more than a year out than the initial cases. So my talk will be entitled Pulmonary Pathology in COVID-19. I have no relevant disclosures. We're going to start with diffuse alveolar damage and the acute respiratory distress syndrome. These are really the foundation of what's going on in many patients with COVID-19. Certainly not all patients with COVID-19 have DAD and ARDS, but many of the fatal cases do. And so this is really something that everybody should understand. The first indications that ARDS was associated with an increased risk of death came out very early in the pandemic from China, as expected. And the series looked at a sort of a cohort of 191 patients who were inpatients. So these were all hospitalized. And the ones that had ARDS out of them were about 59, so 31%. About a third of them had ARDS. Of those 59 patients, 50 of them died. So it shows you what a high correlation there is between people who develop ARDS in COVID and then the ones who die. There were only 9 survivors in this group. To put things in perspective, I like to look at it in terms of the things that pathologists, at least anatomic pathologists, look at a daily basis is cancers. So my specialty is lung cancer. And so I look at one of the most lethal, if not the most lethal cancer in the United States. So deaths in 1 year from the United States currently are about 142,000 from lung cancer, 42,000 from breast cancer, 33,000 from prostate cancer, 6,000 from melanoma, about 2,000 from thyroid cancer. And you can see that COVID vastly outstripped all of those last year with 281,000 deaths. And, there's probably more because I compiled this data a little before December 31st. But you see the point is that just the enormous impact in terms of human life that COVID-19 has had. And with all that, worldwide death, how much pathology did we have? By February 2020, we had only 1 postmortem biopsy from 1 patient. There was really almost nothing. This was followed by 2 lobectomies from patients who were actually examined because they had lung cancer. And so it had nothing to do with COVID-19, but subsequent to the lobectomy for cancer, they developed COVID. And so people went back and looked at their lungs, looking for signs that they might have been, early features of COVID-19 in those lungs. So there was really no complete autopsy or a complete, global picture as to what was happening in COVID at that time. Now, in March 2020, prompted by my colleague, Jared Gardner, who's really, his foresight in this area is amazing. He recognized very quickly that worldwide people were looking for information from reliable sources on what ARDS was. At that time, we didn't even know necessarily that what COVID-19 caused in the lung, but certainly we knew that COVID-19 was causing ARDS, and there was a large amount of disinformation or just plain old confusion. People didn't know what was happening, fear. So he asked me to just put out a YouTube video, just explain to people what ARDS was in simple terms. And I did that in March 2020. Again, at that time, there was no complete autopsy data. One of the editors at the New York Times watched that video and then reached out to me and asked me to help him make a New York Times video on this, along with a few other physicians. And that video came out in April 2020. I'll remind you that at that time, COVID global deaths were 102,700. So 102,000 people had died. And there was zero, published literature on this. Things were languishing in preprint archives. People were building up cases. You know how slowly the literature moves. So this is the video that came out and that Kamran was referencing in the New York Times. You can watch this anywhere. This is available on multiple platforms, including on the New York Times website. It's a very beautifully explained with lovely graphics, and I'd recommend this to anybody. And what it explains is basically ARDS and DAD. So now ARDS is the clinical syndrome and DAD is the pathologic manifestation. And so they don't cross over. In other words, ARDS is not a pathologic diagnosis and DAD is not a clinical diagnosis. So that's very important to stress upfront. What are the criteria for ARDS? There's the A, and that stands for acute. That's onset within 1 week of a known clinical insult or new or worsening symptoms. The RD is respiratory distress, respiratory failure not explained by heart failure. And then hypoxia, meaning low oxygen levels. So everything in the definition of ARDS is clinical. And as you might expect from an entity that's defined in this way, it's sort of a mixed bag in terms of pathology. Many cases of ARDS are DAD or diffuse alveolar damage, but others are organizing pneumonia, eosinophilic pneumonia, acute bronchopneumonia, and they can all lead to this constellation of clinical findings. And we've known this for many, many years, much, much before COVID ever was heard of. There is a radiologic element to this diagnosis too, and that is the presence of bilateral lung opacities on chest imaging. Not at all specific, but it's needed for the diagnosis. Here I've compared ARDS on the left-hand side with normal lung on the right, and you can see normal lung is beautifully aerated and therefore black. ARDS is, the lung fills with all that debris and is therefore white. And sometimes you get complete whiteout of both lungs. There's a large list of causes of ARDS. The most, well characterized are sepsis and infection, but there's also shock, toxic inhalants, drug overdoses, sometimes, drugs of abuse, chemotherapy, very well known, like things like bleomycin and other forms of chemotherapy, toxic ingestants, aspiration, especially of gastric acid, irradiation can cause DAD and ARDS, pancreatitis, massive blood transfusions, and also major trauma like you get in motor vehicle accidents. Now, how does infection lead to DAD? Like, what is the sequence? How does a viral particle that you're inhaling eventually get to the lungs and cause damage? So here's a beautiful little sort of graphic that was made by one of the people at the Cleveland Clinic named Mark Sabo, and it really beautifully shows what the sequence of events is. So I'd like to play it for you here. So the virus are these little yellow particles, and you can see they're going to the back of the nasopharynx, infecting cells all over the nasopharynx and moving down the airways, down the trachea, bronchi, into the smaller bronchi as they branch, and going further and further and further till they hit the smallest bronchi, and then the bronchioles, the ones that don't have cartilage, and then they get to the lungs, the alveoli. So that is the sequence of events in COVID-19. Now, as the virus gets to the alveoli, this is the sequence of events that happens. Now, remember, the yellow little dots that you will see are viral particles. And now see what happens. So the viral particles come in through the bronchioles, infect the alveolar epithelium, and we know this now by numerous studies that there's actually SARS-CoV-2 in alveolar pneumocytes. It damages the pneumocytes, causes debris to accumulate within the alveoli, damages the endothelial cells. I'll repeat this. It damages the endothelial cells, and this is common to all forms of DAD, is that the injury that causes DAD is diffuse within the alveolus, not necessarily diffuse within the lung, but diffuse within a particular alveolus. So it injures the epithelium, the endothelium, the interstitium, and all that debris accumulates within the lung. Another thing that happens because of endothelial injury is that endothelial cells, the capillaries become leaky and they leak plasma proteins, fibrin, fibrinogen into the alveoli. So that mixes with the debris. And what you get at the end of it is what we call hyaline membranes. So as you follow this, you'll see that at some point you see these hyaline membranes starting to form. And that's these pink linear structures that are on the inside of the alveoli. So this is the mechanism by which DAD occurs in the lung, and then sometimes that gets superimposed with bacterial infections. So that's the sequence, and this sequence is confirmed by beautiful immunohistochemical studies like the one done by Martinez et al. From the CDC, from Sharif Zaki's group. Just a beautiful study that came out early in the pandemic and showed that there were actually viral particles in the bronchial epithelial cells. So you can see here in red, in the alveolar macrophages, and very interestingly to a lung pathologist, also in the hyaline membranes. So one way to think of it is, let's say you are, just think of it as if you're diseased and your body is riddled with smallpox and it disintegrates, that disintegrated debris will also contain the smallpox particles. So that's how you can think of why hyaline membranes also have SARS-CoV-2 particles in them. The CDC group also did beautiful electron microscopic studies that showed actually presence of viral particles in these alveolar pneumocytes and in the macrophages and hyaline membranes. There has subsequently been a lot of controversy about other things that have been misinterpreted as viral particles, like normal cellular organelles. We don't have time to get into that here. Our own study, in collaboration with pathologists from Arcana Labs, Alejandro Bresrocha and Christopher Larson, using some of our material, showed that indeed some of our lungs, the COVID lungs that we gave them, were actually positive for SARS-CoV-2 by in situ hybridization and immunohistochemistry using commercially available reagents. So SARS-CoV-2 particles in many papers are present mainly in the lung and not in other organs. In this particular paper, we couldn't find anything in the kidney, for example. So what happens at the end of this picture? Well, you get this histologic picture that's shown on the left-hand side. That's diffuse alveolar damage with hyaline membranes, thick alveolar septa, and you can see the marked contrast to normal lung. And as this process becomes more advanced or organizes, as we say in lung pathology, fibroblasts and edema come into the interstitium. The interstitium gets even thicker, hypoxia gets even worse, and the hyaline membranes start to disappear. So ARDS is a result of sudden severe injury to the lung from any cause, but when ARDS develops, oxygen levels drop and mechanical ventilation is required. This is exactly the sequence of events that happens at least in a subset of SARS-CoV-2 fatal cases. Now I'd like to briefly touch on COVID-19 Autopsies, Oklahoma, USA, which was our paper, the first published report in the world of complete COVID autopsies that came out in April of 2020. So again, this was, at the height of the pandemic, when we had virtually no published information, and there were about 102,000 deaths. The co-authors were Dr. Lisa Barton, Eric Duval, Edina Stroberg. These are all, forensic pathologists from Oklahoma, and then Shuba Ghosh, who is a expert thoracic radiologist at the Cleveland Clinic. This paper had a lot of impact because it was, because of the timeliness of the paper and because people were looking for answers at that time. It's now been cited almost 500 times, which is unimaginable for me. Has an altmetric score of 820, which is second highest of all time from the American Journal of ClinPath. Was featured in Scientific American. Again, I would never have imagined that my career would ever come to this, and also IdeaStream from NPR. What we showed is that these patients who were not known to have COVID before autopsy were actually proven to have COVID by postmortem PCR testing, either by a nasopharyngeal swab or both by nasopharyngeal and lung swabs. The first patient had a history of fever and chills for 6 days, and a history of hypertension and remote splenectomy, but no other illness, and actually presented just as he was trying to get to the hospital. He actually arrested en route to the hospital, unfortunately, and then died without any chance to get any therapy or mechanical ventilation. So from the scientific point of view, what this case does is it shows you a case of pure COVID-19 diffuse alveolar damage without any superimposition of treatment-related injury or oxygen-related injury, which so often confounds the picture. So in this particular patient, this is the postmortem chest radiograph, and you can see that there's bilateral complete whiteout of both lung fields. And this is what the autopsy images from the lung look like. The black arrows point to hyaline membranes, which I've already explained how they happen. And then the green arrows point to relatively uninvolved capillaries, which I wanted to show because there are many, many papers that show or claim the presence of thrombi or microthrombi in the lung, but this was not seen in our case. There was also a lot of inflammation in this particular autopsy case, both within the bronchi, which you can see have a greatly edematous mucosa, shown by the red arrow at top left, And then inflammation also in the interstitium, which I'll show you in the next slide. The inflammatory cells, as you can see, are mainly lymphocytes, which have been confirmed over and over by numerous studies that the main interstitial inflammatory component is lymphocytic, as you would expect in a fatal viral infection. We did a little bit of phenotyping here, and as expected, these cells were T lymphocytes, CD3 positive, and a mix of CD4 and CD8 positive T lymphocytes. Case 2 was different and actually brings up a completely different issue, which was then subsequently debated widely, both in the medical and in the lay medical literature and in the lay press, which is the difference between dying of COVID, meaning somebody who has COVID and COVID is the factor that kills them, versus dying with COVID, meaning that COVID might have contributed to the cause of death, but it's not clear that COVID was the main cause of death. So in this particular patient, the patient was younger, had a history of myotonic dystrophy, which predisposes to aspiration, and then again died after a few hours in the hospital without a known diagnosis of COVID, which was subsequently found to be positive for SARS-CoV-2 by nasopharyngeal swabs. This patient had an acute bronchopneumonia. As this picture shows you, there's filling of the air spaces by neutrophils. There's an aspirated food particle at top right. So this is classic aspiration pneumonia, and there was no DAD in this case. Now, other autopsy studies that followed ours actually confirmed that DAD and acute bronchopneumonia are actually the common findings in COVID autopsies, and added also that there is thrombosis. So these papers came out from Mentor, Wickman, and Lax. These are all European studies and had greater numbers of cases and essentially confirmed our findings. These came out in Histopathology and the Annals of Internal Medicine. And they confirmed that DAD is very common in fatal COVID-19. You can see the pictures on the right-hand side and the citations. You must remember that DAD is not specific for COVID-19. So DAD happens in a large number of etiologies that I've gone over before. Here's a case of, on the right-hand side, DAD in H1N1 from a case I saw in 2009. Many studies have also confirmed that bronchopneumonia is common in COVID-19. The 3 studies I mentioned before, plus there's a nice study from the Mayo Clinic, which also shows that actually aspiration is a fairly common finding in COVID autopsies for some reason. We are increasingly recognizing that thrombosis is a common finding in fatal COVID-19. Numerous autopsy studies have shown thrombi to various extents, although the numbers vary widely. Everybody agrees that thrombosis does occur in COVID-19 as it has in other infections in the past. These are some of my favorite images from the Wickman paper from Annals of Internal Medicine, showing thrombi both in the pulmonary vessels on the left-hand side and most strikingly in the prostatic deep vein plexus on the right-hand side, which seemed to be a common finding in their male patients who were autopsied. The Mentor study also documents microthrombi within the pulmonary alveolar microcirculation. Some people have used stains for fibrinogen and fibrin and so forth to demonstrate these thrombi. I will remind you that thrombi in small pulmonary arteries are a common finding in DAD regardless of cause, as Dr. Katzenstein had mentioned in her textbook, and as Dr. Tomaszewski, one of my neighbors here in Cleveland, had mentioned in this classic finding in 1983. I'll mention this again, 1983, we knew that thrombi happen a lot in DAD regardless of cause. So I get deja vu when I remember studies like this, like one that came out from the University of Michigan in 2010 that said that they had both DAD and thrombi and that this combination might be unique to H1N1 influenza. Of course, now we know that it's not unique to H1N1. And of course, COVID is another very classic disease that gives you this combination. So if you see an autopsy with a finding like this, it's not necessarily COVID-19. In fact, this is one of the H1N1 cases from 2009 that I was talking about. Larger studies, all the larger studies have essentially added cases to the findings that the initial studies had provided. Here's a study from New York City that showed DAD in 87% of cases, acute inflammation, including bronchopneumonia in 43%, large thrombi in 32%, and microthrombi in 65%. Subsequently, we have looked at surgical biopsies, mucus plug excisions, lung transplants from COVID patients, debridement cases. And one of them is this astounding case that you see in the top left, which we published. The first author is Dr. Scott Asif. He's one of the pulmonary pathologists in our department. who wrote up a series of these cases that are showing late complications of COVID-19 in people who have lived with this for a while. So this is the paper. It just came out in the American Journal of Clinical Pathology. It is now online and on PubMed. And what this looks at is 3 patients who tested for COVID positive, then underwent mechanical ventilation and ECMO. And this went on for a long time. And so then they had some kind of a surgical resection or autopsy later in the course. So the longest case is on day 126. So this patient survived with ECMO and ventilation for 126 days and then underwent a bilateral lung transplantation at our institution. So this is a very rare case. So we wanted to share our experience with the histology in these cases. What we found is in some of the case that I showed you with a rent in the pleura, the lung on the right-hand side had just completely liquefied and it had infarcted and was colonized with candida. The second case, which is shown in the middle images, showed just a diffuse pulmonary fibrosis. Very much, to my mind, looks like a organizing DAD going into an NSIP-like look with small areas of honeycomb change. And then almost the same histologic picture in the transplant case with a diffuse pulmonary fibrosis, small areas of honeycombing, and then filling of the air spaces with hemosiderin-laden macrophages and foamy macrophages. So there is a definite histologic evidence of long-term sequelae in these very severe COVID patients. And I think that does shed some light into the long-term sort of, the stigmata that happen with COVID-19. It is not, you cannot assume that once the patient recovers that everything will go away. In fact, radiologic findings are increasingly suggesting that some patients who survive COVID have residual pulmonary fibrosis. So to summarize, I'll just say that the COVID-19 pathology is characterized by diffuse alveolar damage, bronchopneumonia, thrombi, and now we know also by interstitial fibrosis. That's one of the late complications of COVID-19. Now, before I stop my presentation, I'd like to show you a very quick thing from the ASCP. Now, the ASCP has a very special feature called the ASCpedia, kind of like encyclopedia plus ASCP. It's like a portmanteau word. And what this wants to do is it's like a library of collections of images that are available to all the ASCP members, as well as anybody with an ASCP account, which anybody can do. You don't have to be a member. And you can go in and look at all these images. So the COVID autopsy cases that I showed you from our first paper are available free to everybody, open access, and have been since April 2020. So I would like to highlight what ASCpedia is. This is done by the ASCP staff. And I'm going to show you what happens if you click this annotation slide here. It brings up a window where you can actually see the whole slide image. And if you click on the annotation, it will give you notes that I put on particular points of this slide. You can also, like all other whole slide images, you can go in at higher magnification, navigate to the point of interest that you're interested in, and you can go to as high as, very, very high magnification if you're interested in the cellular details. For people who really like to look at the details of pathology, this kind of resource is absolutely invaluable because it gives you much more detail than a single photomicrograph can give you. And it's open access courtesy of the ASCP. So shout out to ASCP, very, very important resource for our members. And with that, I'd like to thank everybody for inviting me, and thank you very much for your attention.
Thank you so much, Dr. Mukhopadhyay. That was a really excellent presentation covering some of the surgical pathology findings in COVID-19. So our next talk will be from Dr. Colleen Kraft, and Dr. Kraft is currently an associate professor and the associate chief medical officer at Emory University Hospital. She completed her undergraduate studies at Taylor University in Indiana, where she went on to also complete her medical degree at Indiana University. She then moved to Atlanta, where she was a resident in internal medicine and a chief medical resident at Emory University, followed by fellowships in both infectious disease and medical microbiology. Following her training, she stayed on at Emory University in the Division of Internal Medicine, where she's an academic infectious disease doctor and medical microbiologist. She has particular interest in the microbiota of the gut. So she founded the Emory Microbiota enrichment program in 2012 with a gastroenterology colleague, and has basically focused on the performance and follow-up of fecal microbiota transplants, which is a really interesting approach to treating recurrent C. difficile infections. So that's been the focus of a lot of her work. She also serves in professional capacity, serves in a number of NIH study sections, and is the current president-elect of the American Society for Microbiology. Also in her honors, she has received many awards for her mentoring and educational efforts, and we're very pleased to have her here today to talk to us about COVID-19 testing circa today. So I'll turn it over to Dr. Kraft.
Thank you so much, and I really appreciate the opportunity to be in this virtual pathology grand rounds and to follow my colleague Sanjay, who did such a great lecture. One of the most wonderful things is to actually, to be learning as you're about to be speaking. So I appreciate very much your lecture. So my lecture today, I think, again, following such a wonderful presentation, my lecture today is going to be a little bit tongue-in-cheek because I don't know that anybody on this call really needs to learn about how to make decisions about laboratory testing. But I am going to figure out, or I am going to try to harness what clinical decision-making and what really we struggled with throughout the last year. Again, I know that knowing whether something is an antigen or an antibody or a PCR is pretty known to this audience, but we want to talk about how we kind of get pressured and what we learn through these types of scenarios. I don't have anything to disclose, and the objective for this, actually, I did want to be funny about the disclosure that really I'm using this as a need for catharsis for myself, since I wanted to actually talk about a lot of these issues in some sort of format, because I think it's been a really interesting journey this year for clinical decision-making. But the official objective is that you'll understand decision-making for COVID testing based on test type and patient population. And I hope to go through some interesting discussions about how we made those decisions. So I guess January 2020, we used to make we made test decisions by choosing a test for a specific analyte. We would support and plan for the testing, including staffing. We would then scale the test to serve the healthcare needs and align the testing with the needs of the patient and clinician. And over again, we would educate the clinical team and the patient sometimes on the utility and value of the test. But this is sort of how I feel looking back at that time, pre-2020. And of course, it's always hard to do sort of a funny lecture when you're on Zoom and you're not getting any feedback. But I do feel a little bit like Luke Skywalker and think to myself about my previous self, amazing, every word of what you just said was wrong. So that doesn't turn out to be the beautiful way that we made decisions about our testing during the COVID pandemic. So first of all, I know that all of us on these grand rounds had the pressure of, we need a test now. And it doesn't matter that the virus was just sequenced. It doesn't matter that the virus was just discovered. We, by the way, need a test right now. And so obviously most of us sent it out to a referral laboratory or a state laboratory. This is Roy. This is prior to universal masking. I haven't seen his face in a year. But this is Roy getting ready to send out another box of about 100 samples for COVID testing to a referral center. This was not the volume that this laboratory is used to. It has about 4 FTE, but they made it work and worked 7 days a week in the first few weeks of the pandemic. They also fielded hundreds of calls for the results as those wait times grew longer. And we as clinicians and as the laboratorians ended up calling the epidemiologists all day long to get our testing approved if we ended up sending it to the state laboratory. So how we made decisions about what type of tests to bring in. So obviously if we're sending it out and it's taking a long time, we want to bring in a test to our laboratory. So how do we do that? We think about the diagnostic accuracy, which lists all the things that I've shown here among many more. I know that you can come up with many more as well. And then we talk about the implementation, the workflow, the price, the throughput, the turnaround, all those things really matter to us. The platform certainly helps us because if we already have something that we're using for another test, it's always nice to have one platform that you can use multiple analytes on. And then obviously the vendor makes a big difference. But it turns out in this case, really this isn't how we made decisions. We often made decisions maybe on the vendor and the platform mostly, and on something that we'd never really had to do before, which is availability of the test. So we kind of went back to the drawing board because it didn't seem to be that there was a lot of things coming out, but not a lot of things that were immediately available. So we did what our molecular laboratory at Emory Hospital does best. It's under the direction of Charles Hill. And this is actually Dr. Babaker, who was the micro fellow with me at the time of the pandemic, and jumped right in and figured out how to learn how to develop a laboratory developed test. So we had a robust platform with basic reagents that we had EUA approval on March 13th. We were really excited. We'd worked for a long time. We felt like we'd worked for a long time until then to get that up and going. What could possibly go wrong? We have our test, we can go. Well, within a week, we were scrounging for PBS and other reagents from the university and research labs all over. As you will see, we start to enter the time frame of scarcity in terms of resources for laboratory testing. So in March of 2020, we thought that we were somewhere beyond the limits of human endurance. But I think since then, we've continued to scale this mountain over and over again. Again, this is still before universal masking, so this is pretty early on. This is how we were working all of our testing. It was all ordered manually before our laboratory information system group could get it finalized in the computer. And so we had supervisors on the left. Gwyneth on the left is the supervisor. They worked every other day for a few months, basically from March till May. And then we pulled people, laboratorians that were enthusiastic from any area in order to make this work. And I myself came in pretty much 7 days a week to help sort and manage and triage. So I think that was the thing that was interesting the most at that time was, as a clinician, infectious disease physician, and a medical microbiologist, I was very intrigued by the fact that it came down to sort of my decision, which I cleared with many people, about which patients we tested first. So we developed our own algorithm of who was our priority, and we sorted them manually. Then became the swab scavenger hunt. And so all sorts of things became a possible swab. And so we thought a lot about brushing for nasopharyngeal tumors. That became a swab that we could use. We looked everywhere for viral transport media. We looked up recipes to make our own, which thankfully we did not have to do since we validated it in saline. For a while, we weren't sure we could get saline consistently. So I know that everybody's gone through this as well, but it became sort of a scavenger hunt. The picture on the left is one that we actually scavenged out of someone's nose, because if you're swabbing 1,000 people a day, what we had not experienced before is sort of malfunctions with physical swabs. And yeah, this one was stuck up someone's nose and they had to go to the emergency department. So again, the hazards of swabbing so many people in a given 24-hour period. As I thought to think through this cathartic talk, Dr. Alex McAdam, who's the editor-in-chief of the Journal of Clinical Micro, had done some sort of micro comics, which I thought were really good to explain sort of the thought process in clinical decision-making in the lab. So again, this is sort of at our March time. Wow, that was intense. We got our point of care testing up, which we haven't done point of care testing, but we got our SARS-CoV test. We've got some swabs. For a while, we were at the center of the storm. We were on the news. But of course, our work is always important. And I will have to say that even though there was that period where it was all about laboratory testing, for us, we really never stopped being actively involved in all the clinical decision-making, which was really exciting in our system. Some of the other things that to me became a little bit hilarious was that I could tell within a few minutes of when the machine or our automation went down. So we started out with our laboratory developed test. We were able to get an automated test. I'm sort of purposely not using brand names or vendor names because that's not the important part. So the automated tests, as soon as it would be going down or have preventative maintenance, I would start to get emails, pages. Then I would get a call from our tier 5 huddle, which is basically our system level huddle. I might get text messages, calls, rinse and repeat. So I could tell you before even somebody from the clinical laboratory could tell me that the automated platform must be down. And of course, if I'm having a discussion with our healthcare leadership, why don't we already have 2 of these machines already? Well, the whole world is trying to get 2 of these machines, so that's why we don't. And then we also began to experience things in other very strange ways. So for instance, chlamydia and gonorrhea testing became very difficult because the swabs that were used for that were then repurposed for COVID testing. You can see here, for some reason, we also had auger shortages, different types of shortages that we wouldn't have predicted, but that's because resources were really being shunted towards COVID testing. So that was its own sort of Alice in Wonderland. And so thinking just also about how we educate our clinicians, I have to say that our clinicians know better now how to interpret the results of a molecular test and think about diagnostic accuracy than they ever had before this. This is exciting to me as someone that always is trying to translate the laboratory information and laboratory results to the clinician. We actually have daily microbiology rounds so that people can interact and understand how a test is actually, or a test result is created, what are some of the inherent issues with the test, and then also what they can ask about tests that they may not have known. It's not just a result in the computer. So, we have an opportunity to tell people about amplification. So you have here our good old-fashioned polymerase chain reaction or nucleic acid amplification, but where we are amplifying our target. And again, still concerns about, is that a good test or not? So one of the things we learned about and we got to teach a lot about during this time was that your test result and your test, when it's brand new and it's emerging, doesn't have a gold standard. And so we also realized this because we have sensitivity and specificity is something I can't really tell you. What we would use it against would be essentially like a clinical syndrome that we would say, is that the true disease, to compare our diagnostic accuracy against that true disease state, whether it's positive or negative. And so I think that was sort of a journey to try to help people understand that we can talk about the limit of detection. We can talk about positive and negative predictive values, but we may not have that immediate sensitivity and specificity like you can get from other places because we're still sort of developing this test. I think one of the things that the pandemic did for us is that because people's viral load in their noses was so high, that in general, most things were able to detect the virus. But I think as somebody that was such a stickler on sensitivity and specificity before, that was also something that opened my mind that we don't have to have the most sensitive test if already people are going to have a high viral load and it'll be easy to detect. Of course, because we were using batched molecular testing, and we chose not to as a group for whatever reason to go to point of care testing, although I suspect we will be there for outpatient settings soon enough, that rapid testing by other molecular methods will save and fix all of our problems. So this is our Euphoria on the left. This is Terry, the micro supervisor, euphoric with our first set of rapid molecular diagnostics. So isn't this going to be great? We're going to be able to identify and triage people quickly. So yes, that is a great scenario if you have enough supply from the vendor, which we didn't. So then we had to go into the right-hand side of my slide here that just talks about how are we going to use these rapid tests and when are they used and how are they used? And I sort of jokingly say at the bottom, don't bother reading this. This was 60 versions ago. And so it's been interesting that the more that we've taken the reliance off of rapid tests in our healthcare system, the easier sort of everything has been. And actually the more that people plan ahead. So that's been sort of an interesting lesson of trying to make everything faster. There is actually a way to limit that utilization to a more specific group of people that actually need that rapid test. Another thing that was one of my favorite topics for a while was if at first I don't get the answer that I want, I'm going to keep testing. And so this would happen with both negative and positive patients. So negative where they thought that the patient for sure must be positive, and positive patients where they were sure that the patient must be negative. And so we did sort of a look back to see how many COVID results correlated or were sort of had different positive, negative, positive. And so you can see here that there were some kind of unusual patterns, but what you don't see here is the time between each of them. So for somebody that was negative and turns positive, if it's 2 weeks later, that certainly could be a real positive. And so people were really focused on the fact that the rapid test wasn't as good as the batch molecular test. So we actually ended up publishing a paper to sort of put that one to rest a little bit. And we looked at just really high CT values or low viral loads at that end of the spectrum to just define really how they work together. And I alluded to this earlier, but we, as coming from a both clinical and laboratory background, I still really thought that the mantra must be that the best sensitivity is what we always have to achieve. And so we don't want to take patients to the operating room with a pre-procedure testing if it's not with a sensitive test. Well, we've sort of changed our minds a little bit on this. So the needle on the haystack on the right here is reserved for people for coming into the hospital that we need to know if they're asymptomatically infected, if there's any bit of SARS-CoV-2 nucleic acid floating about them. And so we want to know because it's going to make a difference, because even though we're all masked in the hospital and tons of precautions are taken, we can't really afford to have somebody around that's shedding COVID. And so those that batch molecular test was really focused on trying to find those needles in a haystack. We actually still use it for pre-procedure testing. However, we now have switched to other methods that may or may not be more or less sensitive, but it has a lot to do with the prevalence in our area. And so again, I like Dr. McAdams' comic strip where it talks about positive and negative predictive values depending on prevalence. As prevalence rises, positive predictive value rises and negative predictive value falls. So in tongue-in-cheek, he also says pretty obvious. So I think we've kind of come to an idea of there are certain populations, such as our students on campus. We're also a university campus as well as a healthcare system, that there are certain locations and scenarios that are much lower risk of if you have a false negative or false positive than somebody that's going to be coming into the hospital that people are going to be really interacting with. We also had the privilege at Emory of being part of this RADx program, which I'm sure you've heard tossed around in various circles. And so essentially, this was a call for innovative technologies, and my research laboratory actually got to be involved in playing with some of these new technologies and figuring out if they were something that was going to be robust enough to create point of care technology for COVID testing. So I guess I chuckled to myself when I saw the fall of 2020, the deploying millions of tests per week. This is actually a really great program. I think it's done a lot for this pandemic, but as usual, our timelines don't get to be what we predict them to be during this pandemic. The other thing I think that I've learned as a clinician and laboratorian is some of the things that I think are really important for our diagnostics when we no longer have them because the vendor is shunting all their resources towards COVID testing. You begin to wonder if you need some of that panel testing for infectious diseases. And I think that'll be something that a lot of systems and laboratory directors will think about going forward. What do we actually need to test? And if we didn't have this, would we miss it? So we're kind of going through that with some of our test kits for other infectious diseases besides COVID. One of my other kind of maybe not so favorite aspect is I am involved with the way that we do our flu testing every year and how we roll that out. We really tried to prepare in advance for flu testing because we thought it was really important to distinguish between influenza and COVID this year. While the you know, sort of way that they'll be put in the hospital or under isolation may be the same, look the same for both COVID and influenza, we should really make sure that we can distinguish them because of course the treatment is different. Well, it turns out that if everyone's really masking, and even if they're not masking that well, we can still pretty much prevent the spread of influenza. So this sort of seemed like a lesson in futility when you prepare ad nausea for a flu season that doesn't come. So I'm extremely grateful that we've had very minimal flu season. I'm going to knock on wood and hope that that continues. But I think we've learned a lot also from masking during a respiratory season and how much that prevents the respiratory viruses that we're used to circulating. Another thing that's came early on in the form of CSF, if you haven't heard about COVID brain, and I know that Sanjay is a lung pathologist, so we haven't heard too much about COVID and its sort of fogginess for some people. We were asked to test CSF very early. And so while we do send that out, it's not something that we lean on heavily, and we're not totally sure you can ever detect nucleic acid. And I think that story is still being told. But of course, we're asked to test all sorts of different things. And as I was already introduced, I do work with the fecal microbiota program here. And so we have indeed validated a test for COVID-19 in stool. And by the way, most people with SARS-CoV-2 are shedding it in their stool. I think another thing that a lesson learned and things that I've realized is testing is not just about the diagnostic aspect of it. I think it's exciting to think that a test could help sort of open things back up. A test could help sort of activities to occur or not occur. This happens to be Tyler Perry Studios in Atlanta, Georgia. And we actually assisted them in their scenario of creating a bubble. So much like the NBA or some of the professional sports teams kept their individuals isolated, Tyler Perry Studios would test people in the bubble and keep them safe so that they could continue to do their work. And it was just really exciting to think about that a test platform implemented well could actually help things go on sort of quasi-normally during a pandemic. So I hope that this sort of tongue-in-cheek but sincere discussion about some of the pearls and pitfalls or some of the interesting things that have come up during a pandemic was interesting to you. I sort of feel like, you know, the road that I've been on continues to be squiggly. Just yesterday, as I'd already submitted these slides, we were being asked in our lab meeting, now that we have all the resources that we need to be able to actually do the testing that was demanded by the healthcare system, now the healthcare system doesn't want to increase the number of people tested or increase the clinic number. And so again, it's sort of like we're going to be on this squiggle for a long time, just trying to figure out where we land. I do think that we are ready and prepared, and I'm going to say this is better character development than our Luke Skywalker at the beginning, that we're ready for the diagnostic landscape. And I think you're going to see that a lot more laboratories, directors, clinicians, and even film studio directors will understand the value and the interesting aspects of clinical decision-making with COVID testing in the laboratory. So thank you so much for this opportunity. And I think I've left amount of time for questions.
All right, thank you very much to Drs. Mukhopadhyay and Kraft for those excellent talks. It was wonderful to hear both from an anatomic and clinical perspective and a little bit of the story that the two of you and all of us have been on this very interesting year. So if folks have questions, you can type them into the Q&A and I will read them off. The first question is regarding testing. We are having clinicians pressure more and more to release our PCR cycle threshold, which we continue to resist. Can you comment on any benefit of CT from a COVID qualitative test, and should these be released to the clinician?
So thank you so much, Alan. Appreciate the question. We spend our days finding CT values. And so I think that I agree with you that I think releasing it, especially given that it's usually a manual aspect to releasing it, is probably not the best use of a technologist's time if we want to get sort of on the whole spectrum of what's pragmatic and what's clinical. I think that having a way for clinicians to look it up or to have a resource to interpret it is helpful. But I think in general, even though people are much more understanding CT values, it's also hard to compare CT values one to another depending on the platform. Some platforms don't release CT values. So I would say that it's still just really important to sort of not release it unless there's like a super automated way to do that, but also have a way to have sort of some interpretive service if they need it. So our infection prevention group, for instance, uses it when they're trying to decide if somebody should come out of isolation. If the CT value is really high, then they might be more inclined to do that. So I do think it's used in some subtle settings, but I don't think it needs to be out for the general use per se.
Great. Another question, and this is, I think, for Dr. Mukhopadhyay. I don't think there's an indication for routine lung biopsy in COVID patients, but have there been any biopsies performed for other reasons that have shown anything in early stage COVID infection? For instance, someone who got a biopsy or a wedge for a mass?
Yeah, they're right. This is a good question. So the questioner is right to say there's no indication for biopsy in COVID, because we know that the findings are essentially going to be of some form of acute lung injury, either DAD or organized pneumonia or so-called AFOP, fibrinous exudates. The only paper I'm aware of that looks at, incidental findings is the one by Tian that I showed in the beginning of the presentation, the lobectomy study. And in that study, the findings were just a mixed bag of non-specific things, early fibrinous exudates, type 2 pneumocyte hyperplasia, things that, if I saw in a routine lobectomy specimen, I would say this is just, this is either nothing or totally non-specific. So the short answer to that question is nobody has found any specific findings in these types of specimens. In fact, to be completely fair and honest, we have not, even in autopsy cases where we are absolutely certain that those are COVID-related findings, none of those findings are specific either.
Okay. Other questions for Dr. Kraft? Do the emerging variants have any impact on our testing sensitivity?
Yes, so we would say not yet. So far the conserved regions of the virus that we're amplifying, remember that PCR slide where we're using primers and nucleic acids to amplify the regions. So far those are conserved. If the virus mutates enough that those conserved areas would change, then it could potentially have an effect on our sensitivity, and that will make things a lot more complicated a lot more quickly. So I would say that not yet is the answer.
And kind of a related question, does vaccine status and its impact on the disease prevalence change any of our current test characteristics?
Yeah, so I sort of understand this question in a couple of different ways. So certainly we hope that our testing, we will have our prevalence in general should go down the more people that are vaccinated and the closer we get to the sort of herd immunity, if depending on how long that lasts in individuals. So we hope that vaccines decrease the prevalence in general. Now, vaccines themselves do not lead to you testing positive for COVID. And that's something that I say about every day as I'm talking to staff to say, how do I know if the vaccine has worked? Will my COVID test be positive? And so we have to remind them, absolutely not. It's just the little spike protein that's on the outside of the COVID that's put into the vaccine. It's not actually the nucleic acid of the virus itself that's in the vaccine. And so that's been something I've sort of spent most days trying to clarify.
Great. And as a reminder, if the folks attending have questions, please type them using the Q&A session or the Q&A function via Zoom. And I'll read the question and answer it. So A question that I have for the two of you is, you've both alluded to the fact that education has been such a large part of what you've done during the past year. Can you talk a little bit about some of the challenges in educating clinicians, the lay public that you've faced over the past year?
Colleen, you want to go first?
Sure, I'll try to keep it kind. I think one of the things that is to really, I've tried to learn a lot of patience because I was involved in the Ebola work at Emory many years ago in 2014. And sometimes people don't ask or think about it until it's really in their backyard. And so reminding myself that everybody's sort of on their journey of understanding and of it impacting them personally. And if I remember that, then it's easy for me to sort of say the same thing over and over again. I've also, for better or for worse, developed a number of one-liners or ways that I explain things, and so that I say that over and over again. But it is so interesting to me with the deluge of information we have, that still that one-on-one relational aspect is key to a lot of people for vaccine hesitancy, for understanding testing, for how they take care of their patients, for they themselves, should they get vaccinated or should they get tested? And so, I still have almost every day, actually truly every day, somebody is asking me something about, I was just exposed, do I get tested? And so, for me who lives in this 24/7, I say, we don't get tested until we're symptomatic at our place. But people sort of, it's in their sort of distant brain, but not only always in the front of the brain. So I have to remember that I am a resource at all times for individuals. And I think just, kind of having your resources available, it's easy to pass those along. And that's what I've been doing is I know where everything is. So if you need this, you get this. If you need this, you get this. And I try to do as many town halls and discussions as possible.
So Sarah, can I ask you for a clarification? Now, when you say education, do you mean by education of residents? Is that what you're asking about? Challenges in education?
I actually think I was speaking more towards the need to educate folks who maybe are not as well educated as the two of you are in laboratory testing and findings, such as people from the lay public or folks in other disciplines.
Oh, I see. Wow, that is such a difficult question. I think it's for doctors, it's relatively easy to communicate. Scientific findings and the limitations of scientific tests. Very early on, our pulmonologists. So the reason we did the autopsy studies is our pulmonologists and many people in the pulmonology community were asking us questions about treatment. We didn't know any of the underlying biology. So they were saying, well, are these mucus plugs? Are there eosinophils? Are there reversible findings in these patients that we can treat? We are giving them steroids. We are giving them, cytokine blockers. Are these things going to help based on what you're seeing in the lungs? And, in February or around February, March, we had to say, I don't know, because we haven't seen any lungs from these patients, so it was difficult then. But as we started looking at the tissue, we could start educating them about the underlying biology, and that became easy. Now, lay public is much, much harder, lay public, because people come in with preconceived notions, the basic scientific, just foundation may not be there. So I think that's very tough. What I've done, you've seen on Twitter, when you have to discuss findings like this, people come in with their their opinions. I think the best way to deal with that is just put out the fact and then don't try to fight the underlying notion. Put out the fact and defend the fact, but don't try. I don't try to challenge people's core beliefs.
Great. Another question from the audience. What are your thoughts about antibody testing, qualitative and quantitative?
Yeah, so this is also, I did not include this rabbit hole in my talk, but this is also something that I am I'm not sure we've made a ton of progress in the last year about. I think serology in and of itself it's widely variable, which we've always known that. And the way that we've dealt with that is that we've really just narrowed it down that one lab kind of ends up doing one serology. And we kind of know how to handle that. But now we have sort of many labs with different laboratory developed serologies. I think it's been very hard to determine a gold standard. And so, like, for instance, yesterday I was asked, I'm getting one of my colleagues is getting rituximab. My antibody was negative. Do I get a booster? And I'm like, there's no booster. There's no booster yet. But my oncologist is getting me tested for antibodies. I'm like, we can't use that just yet. We just got to get everybody vaccinated first, and then we can decide like if we're going to have some sort of end point. So I think the quantitative part also makes me even more nervous. If we think about the CT value question that we just asked, is that doing it quantitatively, I'm not even sure what that means in a serology unless we can come up with some sort of calibrator or gold standard to compare them all against.
Okay, another question for you, Dr. Kraft. I have heard comments from public health that we need to improve the sensitivity of rapid antigen tests. Is that even possible?
Yeah, so I definitely think that that's possible. We've seen some of that work happen in other antigens such as C. diff, toxin antigens and other aspects. So I do think, even though initially it seemed like a difficult thing to do, I think definitely because you're getting the antigen directly from the nose, we should be able to enrich and make that more sensitive. And I think that that's definitely within reach.
Another question for you, Dr. Kraft. What about confirming the effect of vaccination by measuring antibodies?
Right, and so that's what I was just talking about. I think that that's coming for us, potentially. We need to know how long the antibodies last after vaccination. I think we're still trying to understand how long they last after natural infection. And then depending on the antibody test, is that the right antibody test for a post-vaccinated individual? So these are still, it's a little bit murky to me on that. And I also have to say, what are we going to be using that test for? Like, for instance, if we don't have enough vaccine right now, we're not going to be giving you an additional vaccine. Like, you know, we would get a hepatitis B booster if your titer wasn't high enough. At this point, we don't have the next step to do after we confirm or not confirm that you have antibodies after vaccination.
Kind of feels like, you know, the phrase that I've heard a lot from people is building the airplane while you're flying it. So it definitely feels like we're all in that situation. One more question. Does it make sense to require PCR positivity to disappear before inpatients can be discharged to rehab?
Absolutely not. So I think there's clear CDC guidance about this. It has to do with symptomatology and the duration from their positive test. Now, we do use a caveat in a couple of individuals, like we have an immunosuppressed group that gets that sheds virus for a long, long time. We're not sure if it's viable virus. So we actually have spent a lot of time in our community basically educating rehabs, educating long-term care facilities, and coming up with guidelines along with following CDC guidelines about, you know, getting PCR being negative. But we know that we're going to shed nucleic acid, or dead nucleic acid will be there after sort of symptoms are gone.
Great. All right, and I guess we have a few minutes before our next session starts at 2:15. So I want to thank Dr. Mukhopadhyay and Kraft again for your wonderful talks and for answering these very difficult questions. And we will start up again at 2:15 for the next series of talks. Thanks, everybody.
Thank you so much. Thanks for the invite.
Hi, everyone. Welcome to the second half of the VPGR ASCP kickoff event. It's my great honor to introduce our next speaker, Dr. Gary Prokop. Dr. Prokop is the Vice Chair of Pathology Education and the Director of Molecular Microbiology, Virology, Mycology, and Parasitology Laboratories at the Cleveland Clinic. He completed a bachelor degree at Eastern Michigan University, followed by an MD and MS at Marshall University School of Medicine. He is followed by residency training in anatomic and clinical pathology at Duke and a clinical microbiology fellowship at the Mayo Clinic. He has given more than 690 scientific presentations, 234 published manuscripts, 51 chapters, and 3 books to his credit. He is a member of the Board of Directors of the ASCP, the Chair of the Commission on Science, Technology, and Policy, and a member of the Effective Test Utilization Subcommittees of this commission. He will assume the role of CEO of American Board of Pathology on January 1st, 2022. Dr. Prokop is the recipient of numerous clinical research and teaching awards, including the ASMBD Award for Research in Clinical Microbiology, the CAP Distinguished Patient Care Award, the Cleveland Clinic John Hazard Teaching Award, the ASCP Mastership Designation, Case Western Reserve University School of Medicine Scholarship in Teaching Award, and Belinda Lieberman and James Lieberman Endowed Chair in Clinical Microbiology. His primary interests are developing and promoting best practices in laboratory testing, the practical application of molecular diagnostic methods for the diagnosis and treatment of infectious disease pathology, mycology, and parasitology. And last but not least, he's currently working on a Master's of Education in Health Professions through Johns Hopkins University. Dr. Prokop, welcome.
Thank you. Thank you for such a nice introduction. I appreciate it. And I want to thank both speakers. It's been a great afternoon so far. So hopefully I don't drop the ball on you. Wonderful talks. I think Dr. Kraft and I had almost every experience the same. And of course, wonderful to share a workplace with Dr. Mukapade. So thank you again for the organizers. You've done an incredible job. And so I was asked to speak on the importance of laboratory medicine and helping to guide future health policy and have a discussion around national testing strategy for COVID-19. And so the way I've done that is really trying to be reflective. And so we're going to look back at the last year, reflections on laboratory medicine, health policy, and COVID-19. And if, no matter what part of our life we're in, if we're ever going to improve, we have to be willing to open up and be introspective. We have to be open to constructive criticism. So I want you to know, as some of these reflections are not going to be pleasant, and if they reflect poorly on any particular aspect of government, institutions, anything, it's not personal. I would invite everyone to think openly. As we go forward, I would like us all to ask ourselves, if we had to grade our response over the last year to a respiratory viral pandemic, COVID-19 pandemic, how would we fare? If you were to enter into the chat our score, with 10 being outstanding, we executed on a pre-developed plan and everything went perfectly, versus, we ran around like a bunch of Keystone cops and didn't really seem to know which way was up, number one. Where would we fall in that 1 through 10 Likert scale? And so when we think about that, I think we can then start drilling down on, well, if we didn't do as well as New Zealand, who I think probably set the bar for how to actually respond to a pandemic, if we didn't do as good as New Zealand, where did things start to fall apart? And so you'll see some of those in these reflections. You may not agree with all of them, and that's totally okay. And please, put it in the chat as you like. Next slide, please. So I have, and we've already seen, I have no disclosures. And so I think you probably could substitute my picture in the center or Dr. Kraft's picture in the center. And I think, this is probably how we felt many days. And the really question is, could we make this any more complicated? If we thought about how to make it more complicated, could we do that? And I think that it would be pretty tough. We've got groups like CDC telling us what we should do, groups like FDA telling us what we can and can't do, groups like CMS, telling us what we can be paid for, and having oversights of our hospitals and laboratories, state regulations coming down the pike, and then of course, as Dr. Kraft mentioned, we're being pulled every which way within our workplace. The first time I think the C-suite may have known that we have microbiologists on site, and then actually wanted to see us and were calling us on a regular basis. Clinical providers with a variety of questions requiring guidance, because we really are the testing experts, right? Our administration either wanting things or us needing them to do things for us. Can we get additional testing platforms, et cetera? And then working with infection prevention. And I just didn't want to add any more to this messy picture, but I think this is probably how many of us have felt for the last year. And Dr. Kraft clearly articulated why. And let's drill down on some of these and reflect on ways that perhaps it could be better if this happened again. So next slide, please. First of all, before we go on, was this a surprise? We have been talking about the repeat of the 1918 influenza pandemic since it stopped. We are always hearing about new variants coming out. Things are gearing up. This was not a surprise. This is something that we should have had a plan in place for. And it is just so sad that our response was so poor. And I think the positive attributes of everybody who stepped in and really did act heroically makes the heroic efforts that much greater, because they were put in really no-win or very difficult to win situations. So let's talk about preparedness or lack thereof. And so first of all, public health funding. Please put it in the chat if you think our public health partners are way overpaid. It's actually terrible when you look, and it's not COVID related, but when you look at the amount of spending in the United States on healthcare compared to our outcomes, it's bordering on criminal. By the amount we spend, we should have much better outcomes. And some of that money is not going into public health like it should. So we've got a group of public health individuals who are heroic, who are woefully underfunded. Public health expectations. We really have unrealistic expectations. And I think we can all come to an agreement on that. Early in this pandemic, and Dr. Kropp mentioned it, we had a situation where only public health could do this testing. That's ridiculous. We'll talk about how we have laboratories in all of our more sophisticated locations that are doing tests that are more complicated than SARS-CoV-2 tests. We should have been testing broadly early. It's an unrealistic expectation. It's an impossible expectation to think that public health, as currently funded, could ever do all the testing needed for a respiratory viral pandemic. We saw our largest, most efficient laboratories, reference laboratories, bogged down so that our tests were being returned, a week or more later, because again, lack of overall organization and guidance. Again, I think we can all agree this idea of political involvement in public health decisions is just, it's nothing short of disastrous. And we've got to figure out a way how to deal with that going forward. So these are our three thoughts. And next slide, please, are some thoughts on what could we possibly do to improve this. Well, with regards to public health funding, I think it first comes down to actual decisions. What do we want our public health to do, and what don't we want them to do? And we need to have this solidified at the federal, state, and county level. We have counties that don't have health departments. If we have a county without a health department, you're not going to have a county response. So we need to understand and agree to what do we want public health to do and what isn't their job at a federal, state, and county level. And then we need to fund it in an appropriate manner and make that funding sacrosanct. Years ago, I looked at a job at CDC, and I found out from folks there that every year they run out of funding, say in September, and I don't know if they work on papers from September to the new funding cycle or when, but that's not how you would want to run this if you could do it from scratch. So we need to have this more thought out, fund what we really want to have happen, etc. And I think we could have expert panels. This doesn't all have to fall to the government. Expert panels that could decide what needs to be done in which levels, and federal and state dollars could be tied to compliance. When you have jokers like governors who decide to take masks off in an ongoing pandemic, I mean, they should be punished. And the only way we apparently can punish them is with dollars. But those types of things should be done. Next slide, please. Public health expectations. Public health functions in an evidence-based manner that we got to somehow protect from undue political influence. We know that that the commander-in-chief is in charge of the military, but commander-in-chief does not get down into the weeds and tell troops where they're going and where they're not going and those types of things for the most part. Similarly, yes, I understand that there will be broad governmental decisions on what type of topics should be attacked by public health, cure for cancer, et cetera, versus we're going to attack COVID-19. But somehow we need to keep people who are not scientific experts out of the guidance for public health. Given the infrastructure, as mentioned, it really is, and I think everyone would agree, inconceivable that public health as currently funded could do all of our respiratory viral testing. So if they couldn't do it, let's not expect that. What is public health great at? Well, look at CDC. CDC is global. They're uniquely positioned and staffed by real experts to develop, validate, and make scientifically accessible assays for emerging pathogens. That is a thing they should do. And I give them credit, that was done in this pandemic. The first assay we brought up was the CDC assay, and it worked wonderfully. However, this was not the case with Zika virus. And some of those primers and probes were kept proprietary for a while, which is not right if it's publicly funded science. And hopefully that's why it was handled differently for COVID-19. And so again, if that's learning, I give them credit for that. But this is a great job for CDC to do. And then us that can do testing, who have never seen these because of maybe a lack of a global presence, we can utilize those tests, verify those in-house, and bring them up quickly in response to a pandemic. And so I really think this idea of a public-private partnership is the way to go forward if we're going to have to respond to an infectious agent like SARS-CoV-2. We've already said the public health can't do it by themselves unless you're going to fund them in an unbelievable manner. Then the only way we can do it is how we have had to scramble to do it, and that is in this type of a partnership. So next slide, please. So let's talk a little bit about regulatory misadventures. And so it has not been a short time, it's been a long time. It's been years and years and years that we have been talking about FDA and their position on laboratory developed tests. I will say, because that was not resolved, there were worse outcomes during this pandemic. If it had been decided that laboratories of X amount of competence can bring up LDTs of their choosing, I'm doing LDTs right now for Epstein-Barr virus quantitative PCR that's more complicated than COVID. as well as BK virus. These don't require an EUA. They are done in a CAP certified laboratory under good laboratory practices, all of my compliance and accreditation in order. Why couldn't I just do that for a SARS-CoV-2? Instead, I had to jump through all of these hoops or wait for somebody else to jump through the hoops and use their assay, all of which is costing us time. When we did decide to jump through hoops for some of the EUAs that we submitted, we did run into a bureaucratic quagmire. We had reviewers change midstream, new questions when old questions had been already answered. Very frustrating in the midst of a pandemic. Next slide, please. So we need to have a plan in place on the books. We've stressed that once already. We knew a respiratory viral pandemic was coming since 1918. We've had enough time to plan for it. Why do we not break the glass? I know from the picture on the left, the first thing we want behind the glass is toilet paper, because for some reason, toilet paper seemed to be very important in this pandemic. I still don't understand why. Dr. Kraft told us it is a shed in the stool. Maybe they knew something we didn't, but apart from toilet paper, we need to have a plan. We need to have a plan for any respiratory viral pathogen that can replicate at a pandemic level. What's the plan? We need to have a plan when a blood or body fluid borne pathogen comes on board, comes to the United States. We need to have a plan. We need to have a plan for mosquito-borne transmitted illnesses. And someone's writing in the chat that we had plans, but they were not executed. We'll get to that in the next slide. Thank you for your comments. Next slide, please. So, potential opportunities for improvement. And so with regards to these EUA submissions, et cetera, for example, we were asked to submit the LOD of the assay. The LOD could have been anything from, X approaches 0 to X approaches infinity. Who said what LOD is good and what LOD is not good? I know a lot of experts that could tell us what LODs would be acceptable in particular situations. That's the kind of guidance we need. I don't want to just generate a number and not know what that number means. Now, FDA came back and sent around a very nice panel to assess a variety of assays so we could compare assay to assay, give them a lot of credit for that. But those are the types of things we need to do and again, have this plan from the beginning. I just listened to the FDA update 2 days ago, and maybe it was yesterday, can't remember exactly. They went through the list of EUAs that were processed, huge, crazy number of EUAs. I know that they're working night and day. I know some of the people there. These are high quality individuals. What I would ask is that we ask our high quality individuals who are governmental employees to work smarter, not harder. And for example, there was no reason we had to be looking at serology tests or having any serology EUAs processed early in a respiratory viral pandemic, because if you asked 100 top virologists, they would say that we do not use serology for viral respiratory pathogens. We need to process, if they're going to process EUAs, we need to process molecular tests. Okay. So my argument here would be, and this would help FDA streamline their work, allow laboratories with sufficient skill sets, i.e. those that are already performing assays of similar or greater complexity, my example of BK and EBV, to implement assays that meet the aforementioned criteria as LDTs under the current CLIA regulations. This would streamline their workload. They could concentrate on, I would honestly say, more important topics, and we do want them and do value their input, and we would have tests going to the market much quicker for our patients. Next slide, please. Okay, national guidance. So we're going to have to go all the way back to a Roman Stoic philosopher who said, if one does not know to which port one is sailing, no wind is favorable. you cannot set your sail and make any headway. So I think, and again, you can vote 1 through 10 if you think our response was great. I'm going to make an argument that it was inadequate to, in some instances, actually dangerous. And we've seen various responses 2 days ago from Texas, from state governors that vary from excellent to dangerous. And we have had some excellent responses. I got to tell you, I can't say more good Ohio, and I grew up in Michigan, then this guy has, in my mind, he's done it all right, and he continues to do it right. So it can be done well. Next slide, please. So first of all, while we're giving out kudos, we need a statue for Dr. Fauci, and I think everybody would agree with that. This guy has been our North Star and has not wavered under incredible pressures. I also want to thank the folks at CDC, FDA, our public health for their tireless efforts. I know they've been working 24/7 and their guidance. What I know is they get pulled different ways. They have different guidelines and regulations that many of us out here don't understand. And so what I would love to see is their lives get better so our lives could get better. And I think, I also want to thank our national organizations like Infectious Disease Society of America, ASCP, American Society for Microbiology, CAP, who have all had hands in giving guidance for most appropriate testing, et cetera. And so these national organizations have, again, also really stepped up. So these are things in a reflection that we have really done well. We need to celebrate these as we also look at some of the gaps that have been disclosed. Next slide, please. So what could we do? One of the things I think we should do is we should really establish guidance councils of national experts, and these need to be both public and private. As we've seen, folks that are in federally funded jobs are under the thumb, if you will, of the politicians who happen to be in office at that time, and that may be good or that may be bad. But for example, and I'm really happy to see that President Biden put together a group to look at testing and other aspects. My understanding that much of the testing one anyway, I thought was all governmental employees. We've got amazing leaders in the field. You heard Dr. Kraft today. She needs to be on these committees. Our ID docs that are in the trenches need to be on treatment. So again, you get this idea. We have the resources. This is a matter of organization. And so we need to just get organized and get the right experts into these councils. And then I think what we also really need is we need to have coordination between CDC, FDA, and CMS. And going beyond COVID, we will have CDC ask laboratories to do things and then payers not pay for it. And some of those payers are Medicare, Medicaid payers. So CMS is in there. We really need coordination between these three branches of government and some others. And if there is coordination, we need better coordination. And people are telling me there's a plan. Great. We can move on to numbers 4 and 5. We need a plan. We need to follow the plan. And then we need to have these experts tell us where we need to modify the plan as evidence and science dictates as we move along. Next slide, please. No plan is ever good. My old fencing instructor used to tell me, no plan survives the battle, but those without a plan don't survive the battle either. So don't expect your plan to be perfect, but you got to have a plan and be willing to modify it along the way. Supply chain issues, I'm not going to belabor it. You heard some of it already today. We have had unbelievable shortages in material, unbelievable shortages in personnel. How could we address these? Next slide, please. So first of all, I think there needs to be early incentives for assay development. We don't want to wait till pathogens are on our shores. When we see that there's a potential outbreak in an area, particularly if that extends beyond the borders of that country, and that may be too late, we need to be incentivizing all of our all of our commercial partners to be developing these tests already. Again, CDC making these tests available to folks that can do laboratory developed tests, et cetera. Manufacturers should be incentivized to develop assays, boost production, stockpile materials, and you can stockpile materials and rotate inventory to minimize waste. We need to identify and incentivize manufacturers ahead of time who could be commissioned in the Defense Production Act. It's ridiculous to have all of our swabs coming from Italy and then not be, and having them sitting in a port someplace. These can be thought about ahead of time. And of course, there's probably a whole additional lecture to talk about investment in human resources. Next slide, please. Investment in laboratory infrastructure and qualified personnel. So laboratories have probably fallen into a couple buckets. Buckets wherein there have been investments in laboratory personnel and equipment, and those that have decided to outsource much of their laboratory services. And I'll tell you, the only reason we were able to be the first hospital in Ohio to offer SARS-CoV-2 testing is because we have had support by our institution to build, what is really a high quality laboratory. Those that have outsourced are fully reliant on commercial reference laboratories, and again, staffed by great people, but they were overwhelmed with a deluge of specimens. And we, like Dr. Kraft, had to sit down with our leadership and decide who is going to be tested and who isn't. And people weren't tested, and not all of them are tested to this day. A lot more are than early in the pandemic, but these are important things. So you got to build your pathology and laboratory medicine infrastructure. Next slide, please. And so first, this comes with a recognition that the contribution of strong pathology and laboratory presence in healthcare delivery is really critical to great healthcare delivery. And so to pathologists and laboratory professionals of all levels, what we've got to be is we've got to be indispensable. Your value has to go beyond your test results. And again, that's an entire additional lecture. But I would argue that if we buy local and build local whenever possible when it comes to laboratory testing, it's going to pay dividends in both routine care, and you'll have a laboratory that can respond with heroic efforts when a pandemic arises or other emergency. Next slide, please. So, immediate future need. What's going on right now? One of the things that's going on is we've got variants to track, right? We're worried about variants because of reinfection. We're worried about variants with regards to infection following vaccination, vaccine efficacy. We're worried about changes in increases in transmissibility, potentially increased virulence for some of these. Important, I think, is resistance to monoclonal antibody or convalescent plasma therapy. We need to know which variants will be resistant, particularly if they start to have increased transmissibility, and if they're all going to be covered by the vaccine. Good news right now, looking like they are. Next slide, please. So here is kudos, and I want to call out great leadership from CDC, great leadership from FDA. And CDC is leading a public-private partnership, SPHERES, SARS-CoV-2 sequencing for public health emergency response, epidemiology, and surveillance. And so money is starting to be distributed to states for private groups, our hospital, other hospitals, that have the ability to do next generation sequencing, to put those sequences into use for all of us. And FDA has given guidance regarding the impact of potential viral mutations on COVID-19 tests. So again, kudos to our governmental leadership with regards to your response to variants. Next slide, please. And with that, I would like to just come back to where we started. Many of these things were gaps, and you may not always agree with my opportunities for improvement. You may not agree with my assessment of gaps, but it is an assessment, and I think the important thing is it's on the table. Hopefully it starts discussions. These discussions should be professional, collegial, with the end goal of improving the healthcare of all Americans. I will stop there and move on to the next speaker.
Thank you so much, Dr. Prokop, for the great presentation. We all learned a lot. Our next speaker is Dr. Dan Baruch. Dr. Baruch received his PhD in immunology from Oxford University and his MD from Harvard Medical School. He's currently the William Bosworth Castle Professor of Medicine and Professor of Immunology at Harvard Medical School, Director of the Center of Virology and Vaccine Research at Beth Israel, a member of Ragon Institute of MGH, MIT and Harvard, and part of the Bill and Melinda Gates Foundation collaboration for AIDS vaccine discovery. His laboratory focuses on studying the immunology and virology of HIV infection and developing novel vaccine and eradication strategies. His group has also applied their vaccine expertise to preclinical and clinical studies of other infectious diseases of global significance, including Zika virus, tuberculosis, and most recently, SARS-CoV-2. Dr. Baruch, welcome.
Thank you very much. Let me share my screen. Okay, can you see my slide and can you hear me okay?
Yes.
Okay, very good. Well, thank you very much. It's a pleasure for me to be here with you today. And in the next 20-25 minutes or so, I'd like to tell you about our work on COVID-19 vaccine development, and in particular, almost a personal story of developing a vaccine during a pandemic. So here are my disclosures. So our work on COVID-19 began on January 10th of last year. Our group had never worked on coronaviruses before. We were primarily an HIV research group, but we had dabbled in filoviruses and other viruses, but we had never worked on coronavirus before 2020. On January 10th of last year, we were having discussions at our group meeting, and we were quite alarmed by the reports that day of spread of this mysterious pneumonia in Wuhan to 41 cases, and 1 person had died. We found those numbers to be alarming. Just think about it. Just about a year ago, a little bit over a year ago, 41 cases and 1 death led to the launch of a vaccine development program, not just in our group, but within over 100 different groups worldwide. And in less than a year, the pandemic has exploded before us. Instead of 41 cases, we currently have 114 million cases. And instead of 1 death, we have 2.5 million deaths. It's truly astonishing how a viral pandemic can completely uproot the world, impact each and every one of us, both personally and professionally. The WHO estimates that over 200 vaccine candidates are under development for COVID-19, really reflecting all the different vaccine research platforms that have been developed over the last several decades, including DNA vaccines, RNA, protein, vectors, and activated viruses. But I would argue that the timeline to show clinical efficacy is actually not the relevant timeline. The relevant timeline is the timeline to produce and deploy billions of doses of vaccine worldwide. As you probably know, there are now 3 vaccines approved for use in the US for emergency use authorization. First were the mRNA vaccines from Pfizer and Moderna, and just this past weekend is the vaccine that I'll tell you about today, which is the ad vector-based vaccine from J&J. In the US, we have 5 serious vaccine programs that have either completed or are in large-scale phase 3 clinical trials. And if we're lucky, we'll have not only 3, but we might have up to 5 vaccines by summertime. The first 2 vaccines were the new vaccine platform based on mRNA from Moderna and Pfizer. The launch of these phase 3 trials was in July, and efficacy was shown in November, and both of these vaccines were approved by the FDA in December. The J&J vaccine was based on the Ad26 platform. The launch of the phase 3 trial was in September. Efficacy was first announced at the end of January, and just this past weekend, FDA approved it for emergency use. AstraZeneca is the next one coming up. It involves a chimpanzee ad vector. The start of this trial was in August. There were some delays, but we do hope to see efficacy of this vaccine this month. And the fifth and probably final phase 3 trial is from a company called Novavax. It's an adjuvanted protein-based vaccine. The launch of the phase 3 trial was in December, and we hope to see efficacy perhaps later this spring. But these are the 5 vaccines that have been developed seriously by the United States, and hopefully will all become available. So our work in developing the Ad26 vector platform started about 15 years ago, not for coronaviruses, but really as part of our HIV research program. And we developed and cloned and vectorized Ad26 as part of a project that started in 2003. And this is the first paper that was published in the Journal of Virology in 2007, in which we developed not one, but actually a half dozen adenovirus vectors from different serotypes. And it turns out serotype 26 had features, technical features, that ultimately showed that it was a really good vaccine platform. And then we developed Ad26 as a candidate HIV vaccine really over the last 15 years. And our Ad26-based HIV vaccine is still in clinical trials, and ironically, will probably read out this year. The knowledge gained by this vaccine platform initially through our HIV vaccine work, and then with the work together with our industry partner at J&J with Zika virus, Ebola, and RSV really set the stage to be able to develop this vaccine quickly starting last year. So this is a clinical trial with our Ad26 Zika vaccine that was actually just published in the Annals of Internal Medicine. And this was our first exploration of the use of this platform for a pandemic response. In 2016, with the Zika virus pandemic, we developed an Ad26 vector expressing Zika virus envelope protein. And this was taken into a phase 1 and 2 clinical trial with our industry partner at J&J. And this is a 100-person clinical trial in which we looked at the immunogenicity of this vaccine given either as a lower dose or a higher dose, and either as a single shot vaccine or as a 2-shot vaccine. We showed here for Zika that a single shot of this vaccine raised neutralizing antibody titers in essentially everybody, and these titers were durable for over a year. A second shot did boost these titers substantially, but then these declined so that after about a year, 1 and 2 shots were more or less the same. But nevertheless, from our Zika experience, this vaccine platform essentially showed that it could be deployed quickly in a pandemic, although we thought a couple of years was quick back then. And it also showed that a single shot vaccine for a well-behaved virus like Zika, unlike HIV, which of course has unique scientific challenges, but for a more well-behaved virus like Zika, a single shot vaccine actually could raise neutralizing titers in virtually all recipients. So we thought that the use of Ad26 would be a good platform for development of a COVID-19 vaccine. And so where we were in January of last year when we decided to embark on this adventure was that we already had the replication incompetent Ad26 vector platform that we developed as a vaccine vector for multiple pathogens. Primarily through the J&J Ebola virus work, this vector has been shown to be safe and immunogenic in over 100,000 people even prior to the pandemic. Also, there was regulatory approval in Europe for the Ad26 Ebola virus vaccine, so it really was no longer an experimental platform. We also knew that mass production and global distribution was feasible. And for the Ad26 Ebola vaccine, J&J developed a formulation that did not require sub-zero freezing to be able to distribute to Central Africa. For the Ad26 RSV platform vaccine studies, we knew that this vector platform also could be used in children, and there was pediatric experience with the Ad26 RSV vaccine down to kids 4 months of age. So we thought that this would be useful for a pandemic response vaccine because of the potential for a single shot vaccine and no frozen cold chain required. So this is what we did. So on January 10th of last year, the sequence virus was released by the Chinese researchers, we started working on it immediately that same night. And over the weekend, we developed synthetic antigens that could be used as spike protein vaccines. When we got back to the lab on Monday, January 13th, then we were ready to order synthetic genes to start beginning vaccine development work. By the end of January of last year, we signed a collaboration agreement with J&J, which was a natural industry partner, because we had worked with J&J for HIV and Zika and other things. In February, we started to immunize small and large animals with prototype vaccine constructs. And also by the end of February, we developed a viral challenge stock to develop small and large animal models of disease. In May of last year, we had our first publications on natural and vaccine immunity. And in July, we started our phase 1/2 clinical trials. We also published in July the protection of a single shot Ad26-based vaccine in non-human primates. And in September of last year, based on the week 4 data from the phase 1/2 trials, we started a single shot phase 3 trial, which has recently read out. In November of last year, we also started a 2-shot version of this vaccine in a second separate phase 3 trial that's still enrolling. And then in January 29th of this year, J&J announced interim safety and efficacy data of this vaccine. And on Saturday, this past weekend, FDA granted emergency use authorization. And J&J has a commitment to produce and deploy 100 million doses of this vaccine in the United States by June, and 1 billion doses of this vaccine in the world by December. So I'll show you some data from our first preclinical test of this vaccine, in which we show that a single shot Ad26 vaccine protects against SARS-CoV-2 in rhesus macaques. This study involved 52 animals. At week 0, we did a single shot vaccination with 10 to the 11 viral particles of Ad26 vectors. We were actually comparing 7 different versions of the spike protein immunogen. And we also had a large control group. And 6 weeks after vaccination, we challenged these animals with 10 to the 5 TCID50 of SARS-CoV-2 by the intranasal and intratracheal routes. These are viral loads in the lung and bronchoalveolar lavage following vaccination and challenge. In the sham control group, all the animals were infected and had high viral loads in lung, peaking at around day 2 and lasting about 10 days. In the optimally vaccinated group, here this construct designation was called S.pp for technical reasons that I can explain if you want to. This is the vaccine that ultimately went into the clinic. There was no virus detectable in any animals. In nasal swabs, we saw a similar degree of protection. In sham control animals, there was a high amount of virus replicating in the upper airways, and in the vaccinated group, 5 of 6 animals were completely protected, and 1 animal had a low breakthrough for 2 days. We also tested 6 other vaccines that were partially protective, but when we put all the data together, then we were able to look at immune correlates of protection, and we showed that the neutralizing antibody response induced by the vaccine inversely correlated with peak viral loads, here shown in lung, as well as not shown here in nasal swabs. So we were able to start to develop an immune correlate of protection. So this study shows that a single shot Ad26 vaccine resulted in complete protection in the lung and near complete protection in the upper respiratory tract. We thought that a single shot vaccine would have logistic advantages over a 2-shot vaccine for mass immunization and pandemic control. But we also knew that a second shot of our vaccine would likely increase neutralizing antibody titers based on the Ebola virus work. So we thought that clinically it would be very important to evaluate both a single shot and a 2-shot version of this vaccine. We also showed that neutralizing antibody titers were the strongest correlate of protection, consistent with some prior work that we had done with prototype vaccine constructs. So the development plans for this vaccine, which has been renamed Ad26-CoV-2S for clinical development, phase 1/2 studies were initiated on July 22nd with 1,000 participants. And then based on the week 4 results, then we started a phase 3 efficacy study on September 21st. The phase 1/2 data were presented in initial form in bioRxiv in September when the phase 3 study started, and slightly more complete data set were published in January of this year, and basically show that this vaccine was very safe and highly immunogenic in both young adults as well as in elderly adults. So the design of the study is actually the same as our Zika study. There were 5 groups that received either a lower dose of 5 times 10 to the 10th viral particles or a higher dose of 1 times 10 to the 11th viral particles of this vaccine, and either a single shot vaccine or a 2-shot version of this vaccine, as well as a placebo control group. You can see that in general, responses were very low in the placebo controls as well as at baseline. There were a few positives in each group at baseline, and we think these are actually real infections, likely people who were infected during the spring surge. But following vaccination, by day 29 following vaccination, so 4 weeks after vaccination, then virtually everyone had a binding antibody response shown here. And if you look at the summary plot on the right, you can see that nearly everyone had a binding antibody response by day 29. The groups that received a single shot vaccine showed a slight increase from day 29 to day 57 to day 71. And the 2 groups that were boosted, shown in the dark blue and dark green, had about a 3- to 4-fold increase in these titers following the boost. And very similar responses were seen in what was called cohort 3, which is the same cohorts, but individuals who were over 65 years old. If we look at neutralizing antibodies, then we see a very similar finding, that virtually no one had neutralizing antibody responses at baseline. By day 29 following vaccination, then virtually everybody had neutralizing antibody titers. The individuals that received the single shot vaccine had stable or even increasing titers for the first 3 months. And the individuals that received a boost at day 57 had about a 3-fold increase in these titers. And elderly individuals had similar titers as younger adults. We also observed that this vaccine induced both CD4 T cell responses on the top and CD8 T cell responses on the bottom in the majority of individuals, as you would expect from a vector-based vaccine. And ultimately, we think that these actually may have played a more important role than we may have initially assumed in protection against viral variants. So the phase 3 study was called COV3001, which is a phase 3 randomized double-blind placebo-controlled trial of the efficacy and safety of Ad26-CoV2S. It was fully enrolled by December with an enrollment of 44,000, 1-to-1 vaccine placebo randomization, and this tested the single shot vaccine at a dose of 5 times 10 to the 10th viral particles. Importantly, this study was not just a US study, but rather was in 3 major areas of the world: the United States, Latin America, including Brazil, as well as South Africa. The reason why that's important is because over the last several months, we've seen the emergence of new SARS-CoV-2 variants that threaten vaccine efficacy. And I presume you've all heard about that in the media and in scientific literature. It's clear that the pandemic is far more complex today than it was several months ago, in particular in Brazil and South Africa, where there have been the emergence of very worrisome viral variants that are not only more contagious and transmissible, but are also partially resistant to antibodies. That's been seen by a substantial reduction of neutralizing antibody titers by vaccines, as well as individuals with convalescent infection, even to the point where it appears that there is very little natural protective immunity from the original strain to the new strain. The interim results of the phase 3 study are shown here and were updated at the FDA VRBPAC meeting last Friday. And the key thing to realize is this study was conducted in multiple countries. At the peak global surge, the efficacy collection period was December and January, including in South Africa that had 95% circulating virus of the B.1.351 resistant variant. Nevertheless, the protection was very robust. The protection against any asymptomatic infection was 72% in the US, 68% in Latin America, and 64% in South Africa. Most importantly, the protection against severe disease was 85%, and that was global. And that really was the same in all geographic regions. And the protection against hospitalization and death was 100% in this trial, which is really the outcome that most people are worried about. And interestingly, this vaccine that was built on the original Washington sequence gave a very, very high protection, particularly against severe disease and hospitalization and death in Brazil and South Africa, despite these resistant variants. Here are the raw data of protection against severe disease. By day 14, there was already a 77% protection, and by day 28, there was an 85% protection. And later on, the protection is even higher. So this is the Kaplan-Meier curve of severe COVID-19 disease. You can see the placebo and vaccine curves, they really separate on day 7. So substantial protection against severe disease is already apparent 1 week after a single shot vaccine. And although day 28 was the pre-established time point for the primary endpoints of the study, and is therefore what's being reported, you can see that protection actually continues to increase. And after 7 weeks, by day 49, there wasn't a single case of severe disease in the entire 44,000 person study. There wasn't a single case of severe disease in the vaccinated group, whereas there was continuing accumulation of cases in the placebo group. So this just shows the point estimate and confidence intervals of protection over time. Again, the endpoints of the study that were predetermined to be reported were 14 days and 28 days. But you can see that the actual point estimate of efficacy actually continues to increase over time. So it is likely that the next formal analyses at day 56 or day 70 will actually show even higher efficacy against severe disease. And then taking us up to date, on Saturday, as you may have heard, the FDA issued emergency use authorization for the J&J vaccine, which is the 3rd vaccine and is now rolling out in the United States. The second phase 3 study is COV3009. Which is the same vaccine, but given as a 2-dose vaccine. This study is almost finished enrollment of 30,000 and is a 1-to-1 vaccine placebo randomization. Of course, the placebo recipients will now be unblinded and will receive in a very rapid order, will receive the approved vaccine, which is a single shot vaccine. So this actually is going to move from a vaccine versus placebo trial to a comparison, a head-to-head comparison of 2 shots versus 1 shot, which will actually still be quite valuable to see if 2 shots gives better protection or not. And this is also an international study in multiple regions of the world. So the current status of this vaccine, the safety and efficacy is demonstrated in a global phase 3 study, including in the US, Latin America, and South Africa. There's high efficacy against severe disease in all regions studied and all subgroups, including against resistant variants, which is the first time this has been demonstrated for an approved vaccine. The single shot vaccine with no sub-zero freezing cold chain, we think will facilitate mass vaccination, both in the United States and globally. And so this has been approved for rollout in the US, and also it's being rolled out to healthcare workers under an expanded access program in South Africa. And we expect that over the next couple of weeks, there'll be approvals in Europe, in the UK, in Brazil, and in the WHO for the developing world. So I'll just conclude with this perspectives. Vaccine development for COVID-19 has proceeded faster than for any pathogen in history. Safety and public trust are absolutely critical. We believe that multiple vaccines need to be implemented in parallel, since we need to accelerate the vaccine rollout in the US and the world. Viral variants require further study. Vaccines may need to be updated, we're not sure yet, and additional variants will likely emerge. In fact, one of the strongest reasons to accelerate the vaccine rollout, in addition to protecting people's health, is to help stop the emergence or slow the emergence of viral variants in the future that might be even more problematic than the ones we currently have today. And finally, we have to realize this is a global pandemic. If we don't vaccinate the entire world, then we will not stop the pandemic anywhere in the world. There's 7 billion people in the world, and we therefore need multiple vaccines to be deployed as rapidly as possible to end the pandemic. I'm often asked, when will the pandemic end? And of course, I can't tell you that better than anyone else. But what I can say is that I think that in the future, when historians write about the COVID-19 pandemic, and they will for the rest of our lives, then there's going to be a whole lot of terrible things that people remember. But science and medicine are going to be the shining lights showing what the power of science is to hopefully help stop this pandemic. These are acknowledgements for the Ad26 vaccine studies, our collaboration with J&J and multiple other academic groups. And this is a picture of our lab at Bethesda Latinus Medical Center in Boston. This is way outdated. This is a picture of people a year and a half ago when we could congregate like this. And hopefully before too long, we might be in a position where we can take pictures like this again. Thank you very much. And I'll take any questions if there's time.
Thank you very much, Dr. Ghosh. I really appreciate the opportunity to hear you go through and step us through the experiences that your lab has had in the past year. And of course, thank you to all our panelists as well as all the attendees who have joined us for this mega VPGR event today. We have about 20 minutes left, during which we can take questions for Dr. Ghosh, Dr. Prokop. I think Dr. Mukhopadhyay is here as well. If you have questions, please put them in the Q&A. I've seen one or two people kind of put their hands up in the chat. We prefer the Q&A format. We'll see if we can call on you if you're not able to do that. The first question is regarding the phase 1 and 2 trials. For those that had existing neutralizing antibodies, presumably due to infection prior to vaccination, what did the vaccine response look like?
Oh, those people had some of the highest vaccine responses that we've seen, because clearly the vaccine was boosting a pre-existing response rather than priming a de novo response.
Great, thank you. This next question could be directed to either or both of you. Given the lack of a centralized vaccination effort, is it possible that someone gets their first dose of one vaccine and then that same vaccine type is no longer available in the area 2 weeks later? And would vaccination with a different vendor or waiting until a paired second dose is available, would one be preferred over the other? Did that make sense?
Yeah, I think that there's a couple different ways to answer that question. I think that it's always good to stick with vaccines and regimens that have been clinically proven in clinical trials. As soon as you deviate from that, it might be okay, but also might not. We just don't know. So I think that of the 3 approved vaccines, Moderna, Pfizer, and J&J, all of them are very safe. All of them are very effective. But if you get one of the 2-dose vaccines, then it's always preferable to have the boost with the same vaccine in the time interval that that makes most sense. We know from the UK data that there is protection with the 2-dose, with the RNA vaccines, that there is at least moderate protection even with a single dose of those vaccines over time. So if the second dose is delayed, then it's not the end of the world. I just would suggest that you get it sooner rather than later, essentially when possible. But with interruptions of supply, snowstorms, then sometimes it will be delayed.
Thank you. We do have one person with their hand raised in the chat. I don't know if that's intentional. I think we're going to see if there's a way to call on that person, let them briefly unmute to ask a question. It's Francis DeMattia. Are you there, Francis?
Yes, I'm here. Yes, I am.
Oh, thank you. Did you have a question?
No, I did not.
Oh, sorry. Okay.
Sorry.
Well, better safe than sorry. Thank you so much. We do have another question coming in, though. What should we do to depoliticize the attitudes that go against scientific evidence? Obviously a rhetorical question, but your opinions are still appreciated.
You know, it's tough because these things are, they're often like religion. People believe them based on an absence of proof, if you will. And I don't know that you're going to change them. And I think Dr. Mukhopadhyay got a similar question of trying to just put forward the facts, continue to put forward the facts. And I think sometimes if you kind of get down into the weeds and start fighting these things back and forth based on belief, you're going to do nothing but, maybe even strengthen their belief. you sometimes just shut them off. You know, so I actually prefer not to get into those kind of conversations. I would, you know, like to say there is a scientific method, and this is a scientific method that we follow, and this is what it's demonstrated. So, you know, I think the best we can do is stick with logic, and, you know, continue to promote, you know, promote individuals that do, and, you know, don't vote for people that seem like they're crazy.
Yeah, I'd like to chime in here too. You know, I totally agree with what Dr. Prokop said. In fact, if you think, if you step back and think of what changes your mind, you know, if you think of things that where you have ever changed your mind on something, it's generally not something where somebody else tells you that you are stupid, or you made a mistake, or you're ill-informed, or changed your opinion by force. I think that's when we do change our minds, it happens slowly. It happens on our own. It happens because we've read something and convinced ourselves. So I feel that's very correct. It's very, very difficult to change someone's mind by force. And I think if you stick to the facts, put the facts out there and hope that people will educate themselves, that's probably the best way out. I recognize that it won't change everyone's mind, but that's just reality.
That's great. Thank you so much. I do have another question for Dr. Prokop and then a few for Dr. Barosh. And you did touch on this a bit, but in your talk, you focused on broad systemic issues related to the pandemic response. And most of the attendees here are, are more at the local level than that higher decision-making level. What other positive things would you say we can do to help in this process?
You know, I think from the local level, and this has been a huge opportunity for pathology and laboratory medicine to be at the table in decision-making in their hospitals. And, you know, Dr. Kraft mentioned that they were actually at the table, and that occurred here. We've always been relatively visible, but never to the degree, I think, that we were. You know, we were at all the incident command meetings because we knew how many tests we had, what types of tests they were, the sensitivity differences, and we would have conversations along with all the other hospital leaders. So one of the things I think we can do at the local level is don't lose that. They know who we are now. Don't go back into the basement. You know, stay at the leadership table, and no matter what it is, if, you know, if they're building a new cancer center, you know, introduce them to the subspecialty expert in certain types of tumors, making sure we have a presence at molecular tumor board as well as anatomic tumor board, you know, making sure that people see us and they recognize our value. I think that's really important at the local level.
That's great. Thank you. There is another question. In your opinion, and of course, this is an opinion, do you think we would be able to vaccinate all adults by the end of May as the president promised?
Well, I'll get a stab at that one. So that was accelerated in part by the announcement 2 days ago that Merck will partner with J&J for increasing the production of the J&J vaccine. And that's really coupled with an acceleration of the production capacity of the Moderna and Pfizer vaccines. And so if everything works well, and we know in science and production, sometimes there are delays, but if everything goes according to schedule, then there should be enough vaccine available to vaccinate all Americans, all adult Americans by the end of May. That doesn't mean that everyone's going to be vaccinated. I think it will take a while longer to actually get all the shots in the arms, because up until now, the rate limiting factor has been vaccine supply. So there simply hasn't been enough vaccine vials available. Soon that's going to change. And then the rate limiting factor will be the vaccination process. And then, so I don't think that everyone will be vaccinated by May, but it is a realistic possibility that there will be enough vaccine vials for everyone to be vaccinated by May.
That's great to hear. Thank you so much. some slightly related, as you talked about, and as we all know, there have been many groups working on various vaccines during the pandemic, and ostensibly the groups are in competition with one another, but everyone obviously sees the value of having multiple vaccines available. So what opportunities for collaboration arose during the process over the past year?
Well, I mean, vaccine development intrinsically is collaborative. And I think every vaccine developer realizes and recognizes at their heart that they alone are not going to be able to produce and distribute enough vaccine to stop the pandemic. Not a single vaccine developer in the world has ever made the claim that they can do it alone. So the extent of collaboration, cooperation, I think has been unprecedented. I mean, just look at the news from 2 days ago. Two of the biggest pharmaceutical companies in the world, Merck and J&J, have agreed to cooperate in the production of vaccine product. I'm not sure there's any historic precedent of that, but it's a remarkable partnership of two pharmaceutical rivals for the global good. Yeah, I mean, of course, yes, the government helped to facilitate that and streamline it, but nevertheless, then that shows a degree of cooperation amongst the pharmaceutical industry that I don't think we've ever seen before. And of course, there's been more openness and collaboration on the academic research side throughout the whole year.
Great, thank you so much. Can you speak any on vaccination plans for the pediatric population?
So all of the major vaccine developers have a pediatric program. I don't know all the details. I think the Pfizer pediatric program is probably the furthest ahead. And the J&J program is starting, but will go quickly because of prior experience with Ad26 RSV in children down to 4 months of age. So I think that we will see an acceleration of pediatric vaccine trials, and they'll all go in a dose de-escalation fashion from teenagers to younger and younger children down to babies eventually. And I do think that everyone agrees that it would be preferable to get the entire school-age population vaccinated by this fall for back-to-school issues. Whether that's going to be feasible or not, I'm not sure. But there is an understanding that to achieve herd immunity, we do need to vaccinate children.
Great, thank you. Just got another question from the chat. Will at-home tests be approved by the FDA?
There are already 3 at-home tests that are cleared by the FDA. They have EUA clearance by the FDA. I heard there was just a 4th yesterday. I haven't gotten on the website to check it out, but yeah, those are already available. The 3 that I know of, 2 are antigen detection tests, and 1 is isothermal amplification assay.
Awesome, thank you. Another question, much like the Ad26 platform made new vaccine development possible more quickly, do you predict that the mRNA platform will become more widespread, and are there any specific viruses that might be targets?
I think that the success of the mRNA platform and the vector platform for COVID-19 will lead to expanded use of both of those platforms. They're actually analogous. They're both so-called gene-based vaccines. The traditional way of making vaccines is you grow up a huge lot of virus and inactivate it or attenuate it. Gene-based vaccines, you start not from the virus itself, but just from the nucleic acid sequence. And RNA and ad vectors are conceptually analogous. It's essentially the nucleic acid of the COVID-19 spike protein with a delivery vehicle. With the mRNA vaccines, the delivery vehicle is a lipid nanoparticle. And with the vector-based vaccines, the delivery vehicle is an adenoviral capsid. But I think the COVID-19 pandemic essentially has validated both platforms. And it's not, with the 100+ vaccine programs in the United States, 4 out of the 5 large programs are based on these technologies. I would even say the first four vaccines to reach endpoint of clinical efficacy will be RNA and advectors. So I think the short answer is yes. I think there is likely to be seen a substantial expansion of the RNA technology, both for vaccines as well as for other biomedical interventions.
That's great. And, it's good to think about some positive things that might eventually, have resulted from what we've all experienced this past year. Another question from the chat, is there any vaccine that has been successful on pregnant patients or even tested, I suppose?
So the so-called special populations generally are excluded in phase 3 trials, both by industry preference and more importantly by FDA requirement. So pregnancy, rheumatologic patients on immunosuppressive medications, cancer patients, and other populations are in almost all cases exclusion criteria for the phase 3 trial. So then when a new vaccine is approved, then it's awkward that they are actually going to be given to all of these populations, and yet it's been tested on none of them. But there is a growing experience clinically. So there are pregnancy studies ongoing now in which there are clinical trials for pregnant women. But since pregnancy is part of the vaccine rollout, and all the professional societies have basically said just vaccinate them because the risks of the vaccine is small and the risks of getting COVID while pregnant is very high, then there is already a substantial amount of real world clinical experience vaccinating pregnant women. And I presume that will reach the peer reviewed literature very soon.
Wonderful, thank you. I think we've got time for one last question, and this one is actually directed at all the panelists. You can draw straws to see who goes first. What surprised you most about the pandemic experience this past year, and what is the best lesson that you've learned?
I guess I'll jump first if I'm included. So I think the thing that I have learned is just how adaptable people can be in times like this, and that really goes for the way that you practice medicine, or the way that you do your research, or just the way that you interact with other people in terms of making connections through virtual meetings. It really forced us to quickly learn how to do things in new ways, and I think that ability to adapt quickly will really carry us forward as we have to navigate more difficult situations like this in the future.
She took the best answer. That's not fair.
Well, there was a pause and you all let her go first.
We did. It's our fault. No, that's a great one, honestly.
Yeah, well, I would say that what surprised me the most was how, how unaware everybody was of how big a problem this would be in the beginning. That was just, nobody can look back in hindsight and say, oh, we saw this, we knew what was going to happen. I think everybody got caught unawares. And I think the best thing about this has been just the response of the scientific community to this, just everybody, physicians, frontline workers, nurses, everybody in the lab, basic science researchers, the pharmaceutical companies. It's just incredible to see, how you can respond if you come together.
Yeah, I like those. I think there's a yin and yang. If I look at the bad side, is how flat-footed we were caught when we really should have known better. And as mentioned, been talking about respiratory pandemics since 1918. On the yang side of that, as the two other speakers just mentioned, we really came together as an unbelievable group, working with folks we've never worked with, working with people across the city that are usual competitors. all that stuff goes away when it really comes to why we got into medicine. You know, we're here at the end, at the beginning and end of the day for the patient, and we have seen that everybody bringing their skill sets to the full, and you know, really working 24/7. I remember early in the pandemic when everything was shut down, talking to my wife as I was driving in, and I said, you know, the only thing we're missing is the zombies. I mean, it really was apocalyptic, you know, at that time. And so, but you know what? There is light at the end of the tunnel. Thanks. There are vaccine partners and supply chain giving heroic efforts, and commercial partners getting tests on board, and all the other folks that we've thanked. So although there's been missteps, I think the human character has really shined through.
I'll just agree with that completely. I think that this pandemic has shown what the importance and what the power of science and collaboration is, and what it can do. And I think the scientific community has achieved something that is truly unprecedented in the rapid generation of knowledge of the virology and immunology, pathogenesis of this virus, development of therapeutics, as well as the development of vaccines. And I think that is unprecedented, and reflects a global collaboration, cooperation, and a coming together for a purpose that has never been stronger for anything in the past.
All right, thank you so much. I think we are at time. So I do want to say one last time, thank you very much to all four of our panelists, not just for their time and their lectures, but for all their efforts over the past year in combating this pandemic. Thank you to my colleagues on the VPGR team for establishing and keeping the series of lectures going. Thank you to ASCP for partnering with us, and please, keep your eye out for future VPGR offerings through ASCP. Have a wonderful rest of your afternoon, and thank you again, everyone, for joining.
Thank you, Raul.